We are so happy for this. I know everybody's been waiting for the keynote address, and so here it is instead of lunch. I think it's a fair deal, don't you? So first, I would like to introduce Dr. Stephen Lacey, who is the chief of the Division of Public Health. I'm sorry, I'm stumbling because this is my division. This is where I work, and he's my boss. So. So take it away, Steve.
Thanks so much, Yvette. Hello and welcome. My name is Stephen Lacey. I'm the Division Chief of Public Health at the University of Utah School of Medicine. The Division of Public Health sits at the intersection of prevention and primary care in the Department of Family and Preventive Medicine. Our faculty focus on cancer prevention, maternal health, public health emergencies, health disparities, and global health. Our faculty and our alumni have played essential roles in the pandemic response over the past year. Let me also welcome you to the Primary Care Summit. Welcome to our faculty and staff and students, to our School of Medicine alumni, our Utah AHEC scholars, and those joining us from the Utah Asia campus. Before I introduce Dr. Galea, I was hoping that I could introduce Marianne Villarreal, Vice President of Equity, Diversity, Inclusion, to welcome you this week as well.
Thank you, Dr. Lacey. And on behalf of Equity, Diversity, and Inclusion, I want to say, extend my welcome to all of you. And by the chat, it looks like you're having a great time, and it's been an incredible day so far. So I want to pause here before we begin. In October of 2020, the University of Utah published its a land acknowledgement statement, which I'll share with you, but I also want to say and invite you to the numerous events that we're having this month in honor of Native American History Month. And you can find those at diversity.utah.edu. And I want to acknowledge that this land, which is named for the Ute tribe, is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the enduring relationships that exist between many indigenous peoples and their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and urban Indian communities through research, education, and community activities. Our work is just underway, and we have much work ahead of us. As I listened to the preceptor awardees, what I heard about them, along with their expertise, that they placed dignity, the dignity of our human spirit at the center of their work with others. And I want to say thank you to them. And it's also fitting in this MEDiversity week that the intersectionality in healthcare, health education and care, that over the past 20 months, that COVID-19 has underscored clear disparities, hospitalization rates, deaths, the broken communities, especially amongst our Pacific Islander, Black, Latinx, and Indigenous communities. And this further points to the lack of health and healthcare needs or access to populations in various areas across our great state. As infectious disease physician, Dr. Malaki Sharma states, quote, intersectionality is not just an additional way in which we can address health inequities. It requires us to dig deep into our implicit biases and take a holistic approach. But we cannot do this by dissecting one identity at a time. Identities are inherently intertwined and must be looked at holistically, just as medicine requires you to look at the body holistically, end quote. And you'll see that today's panel and many of the events throughout the week will share concepts on how to address intersectionalities and challenge ourselves to pause and disrupt our individual and our systemic biases. I urge you to join us in this work every day. I want to extend now my gratitude to Dr. Stephen Lacey and Yvette Lopez and your outstanding team for partnering with us to bring our keynote speaker, Dr. Sandro Galea, to the University of Utah in celebration of MEDiversity Week, the 6th annual Utah Area Health Education Center's Primary Care Summit, and the George Floyd Memorial Lecture Series. I invite you all to follow us on our social media handles. I often joke I get paid a quarter every time I say this, diversity.utah.edu. And no, it's not just for the University of Utah, and it's not just for the state of Utah, but it's for the work that we do nationally with our partners like Dr. Stacy and Lopez. Drs. Lacey and Lopez. I've had a little too much coffee into the day. So with that, I am going to say one more time, thank you very much. And I wish you a wonderful day today.
Dr. Villarreal, thanks so much for that. As just mentioned, today's keynote address is part of our Racism as a Public Health Threat lecture series. The killing of George Floyd in May of 2020 inspired widespread protests against racism and police brutality in the United States. As a response to that killing and many others across the country, the Division of Public Health instituted this series, which seeks to connect institutional and societal racism with negative health outcomes for communities. It's our hope that by highlighting these links between public health and racism that we see in society, that we can bring understanding, safety, and health to members of our community. I'm thrilled to introduce Dr. Sandro Galea. A physician and epidemiologist, Dr. Galea is the Dean of the Boston University School of Public Health. He is past chair of the Board of Association of Schools and Programs of Public Health, past president of the Society for Epidemiologic Research, and the Interdisciplinary Association of Population Health Sciences. He's an elected member of the National Academy of Medicine. Dr. Galea earned his medical degree from the University of Toronto and previously held academic and leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. His work focuses on social causes of health, mental health, and the consequences of trauma. Given the past 18 months, it's so important that we heard from Dr. Galea today. Next week, Dr. Galea's book titled The Contagion Next Time will be released. About the book, Ibram Kendi said, Galea expertly demonstrates that our investing in the healthiest population possible is literally an act of national security against the next pandemic. Sandro's writing helps us examine the relationships between racism, socioeconomic disparities, and the pandemic, and helps us see a healthier path forward. I suspect we will hear some of those insights today. Dr. Galea?
Thank you very much. Thank you, Dr. Lacey, for that generous introduction. And thank you, Dr. Lopez, for reaching out and inviting me. And thank you all of you for being a part of this. I'm well aware that in these past 2 years, our time has been busier and busier for all of us. And I'm always really honored that people join in these conversations. So thank you for being here. Thank you for being a part of this today. Let me share my screen. So I'm going to talk about priorities for health from my perspective, and I'm doing this to provoke our thinking and really to get into as interesting a Q&A as we possibly can. And I'm obviously talking in the context of COVID and the COVID era. I'm going to start with COVID. I'm going to start with COVID because I think COVID has been very much on our minds. But really what I'm going to illustrate, and I think Dr. Lacey prefaced this in some of his introduction, is how much of what has happened with COVID has been a product of the world around us that has existed long before COVID. And if we are to fix what resulted in the COVID problem, we need to fix much more than focusing on viruses and vaccines. So that's really the broad arc and the thesis of my talk. So I will start here. Now, this might be perhaps a little bit unexpected that I'm starting with a lot went right during COVID-19, because you're thinking, how can you say a lot went right? COVID-19 was a tragedy. And you're right, COVID-19 was a tragedy. But I think it serves us well to recognize where we did go right, so that we can understand why it is that we did some things right and understand why it is that we did other things wrong. So what did go right? Well, I'll start here. This is a slide that looks at death from COVID in a cohort in New York. The gray bars are admissions, but the blue lines, one is adjusted, one's not adjusted, but they behave the same way, reflect the mortality rate from patients admitted to hospital. So what you see is we go from a new disease in March of 2020 with a 25% mortality, and that mortality had dropped to under 5% by June within 4 months. That actually is quite remarkable. It is quite a remarkable adaptation of our health system to a disease that was unknown. I just had never heard of it. And all of a sudden, patients are coming in, sick people are coming in, and our healthcare system adapts and we get good at treating it and drop mortality substantially. And a lot of things led to that: improved clinical care, use of pharmacological treatments like remdesivir and steroids, better non-pharmacological treatments, things like proning, which means dealing with the patient like this. And fundamentally, I think this illustrated that our hospitals and health systems were good, that once people got in them, we actually were good at quickly adapting and quickly treating people. And that, as I'm going to get to in a second, reflects, of course, the fact that we have long invested in hospitals and health systems. Now, our biggest triumph in the time of COVID was undoubtedly vaccines. We achieved 2 vaccines within 8 months of the onset of the disease, both of which were more than 90% effective. It's hard to remember now, but in summer of 2020, we're discussing what will we do if there's a vaccine that's just under 50% effectiveness? Will that be good enough? But no, not 1, but 2 vaccines within 8 months of the disease were ready to go to market, which is extraordinary. I mean, usually vaccines take 10 years. This is an infographic from the Wellcome Trust. And the fastest ever we had in a vaccine before was mumps, which took about 3 years. So this was really a rapid development of outstanding life-saving technology. But it wasn't, of course, just 8 months. In fact, it had been years and decades of investment that got us these vaccines. The mRNA technology is a paper about that mRNA technology. And I like this quote from it. mRNA presents a promising vector that may well become the basis of a game-changing vaccine technology platform. I talk about a prescient statement in a sentence, but this paper is 10 years old, and we have been investing in mRNA vaccines for decades, mRNA platforms for decades, creating the way for them to become effective vaccines when we really needed them. Now, amidst what went right, so much went wrong. So much has gone wrong in the time of COVID. I'll start with the world, just to give us a global lens. This is a global lens of the density of COVID in different countries in the world. The world's been through sort of these 3 waves of COVID, broadly speaking, and things have continued to go wrong as we move to the vaccination. This is vaccination. There's a map of countries where people are vaccinated, and you see the whole continent of Africa has about a 2 to 5% vaccination rate. And for coming back domestically, there were times when it felt like the whole country was on fire. There's a map from the New York Times that they use red to indicate the different caseloads of COVID. And if you were an alien who landed on this planet and you look at this map, even though if you don't know what it is, you would know that something is not right. Like this, really, I like or dislike this map, depending on your perspective, because I think it captures well how I felt during much of COVID. And we've been going through multiple waves of COVID nationally. We're now in the waning days, hopefully, of the Delta wave, and hopefully we'll not have another wave, but we shall see. And of course, COVID has not just been about COVID, it has also been about a whole range of other consequences. This looks at excess mortality from other diseases, not just COVID. And what you see is at the bottom, you have the years 2015 to 2019. The black line is on average of those 5 years. The red line is 2020, where in 2020, the excess mortality from other diseases, death from Alzheimer's, heart disease, lung disease, all were much higher than they are at baseline. At the end of the day, COVID in 2020 was the 3rd leading cause of death in 2020 after heart disease and cancer. Now, remember, we had never heard of COVID in 2019. So we're sitting here in 2021, sorry, and I'm going to tell you that in 2024, there's going to be a new disease that you've never heard of. You've never heard of it right now. I don't know what it's called. You don't know what it's called. We've never heard of it. And that new disease is going to become the 3rd leading cause of death in 2024. What would you say? I think right now you'd think, well, we should do something to prevent that. Like, we don't really want that. We don't want a new disease to come out of nowhere, become the 3rd leading cause of death. So I suppose the reason one has these conversations, the reason we're having this conversation, I presume the reason you invited me, is because we should be thinking about what is it that we should be doing to prevent such a new disease coming and it becoming a leading cause of death again. And I think there's a lot to be learned from what happened during COVID in order to help us get there. Because COVID has resulted in extraordinary health consequences. It has resulted in a drop in life expectancy. That is the largest drop in life expectancy that we've had in this country since World War II. Here you see a drop on men, women, and overall. And I'll talk a little bit more about this drop in a second. Really, COVID has been nationally a tragedy. More than 700,000 people have died from COVID. And when I say 700,000 people, sometimes I think it's too easy to hide behind the numbers, but 700,000 people means 700,000 people's moms, dads, sons, daughters, uncles, cousins, grandparents, lovers. That's what 700,000 people is. These are our neighbors, our friends, people we know, people we love. And that is a lot of life lost to a disease that previously we had not heard of, and a lot of life lost, a substantial portion of which was unnecessarily lost because of ways in which we had actually structured our society, because of the fact that we were sitting ducks for negative consequences of something like COVID, as I'm going to get to in a second. And of course, the experience of COVID was not even. It is not the case that the virus hit everybody evenly. In fact, there were substantial differences between different groups who experienced the virus. Just to focus on one group difference between Black Americans and white Americans, the Black Americans were 2.2 times more likely to die from COVID than were white Americans. The red bar is an adjusted bar, the blue bar is unadjusted. Essentially, Black Americans had more than twice the risk of death from COVID than did white Americans. Other groups were also similarly disadvantaged, including Indigenous Americans and to some extent Latinx Americans. I'm going to focus most of my talk about the Black-white difference, I do not want us to forget the other group differences, but I'm just doing that just for ease in order to help focus our thinking on what drove some of these differences. And just to look at how those differences played out, this is in life expectancy. What you see in the bar on the left is that among Black men, life expectancy dropped by 3 years, by fully 3 years. Among white women, life expectancy dropped by 0.7. Now, a 0.7 drop in life expectancy is already substantial. We had not had we have had some dips in life expectancy over the past decades, but we've never had a dip that's been that big since World War II. So even the 0.7, which is the least drop in any major sort of gender ethno-racial grouping that we're seeing here, is substantial, let alone 3 years. And Black men already are the group with the lowest life expectancy, having a life expectancy of about 13 years in some states, lower than white women, for example. And to have a 3-year loss in life expectancy among Black men is truly devastating. And of course, these consequences have not just been directly held consequences as a direct result of the virus. There have been consequences that have emerged from the efforts to mitigate the virus. One of those being unemployment, that our job loss, our job percentage of population employed dropped to its lowest level since 1975. And that, as with everything else during the COVID pandemic, has not been experienced equally either. When you look at job loss, you see the green line is high wage employment, the red line is low wage employment. Both high wage and low wage employment dropped in the beginning of March and April of 2020, but high wage employment recovered very quickly. And in fact, high wage employment is now 10% above what it was before the COVID pandemic. Low wage employment, by contrast, remains 20% below. In fact, when you look at it this way, you see by income quartile, in the first two income quartiles, meaning in the top 50% of the population, jobs have been gained during the COVID pandemic. It's in the lowest income quartile that jobs have been lost. Because the jobs that have been lost are manual labor, jobs in retail, jobs in manufacturing, jobs that are typically lower paid, and also jobs that are typically occupied by people of color and minority groups. Just to look at this another way, looking at data from Congressional Research Service, this looks at unemployment rate before COVID recession, peak of COVID recession, and current. So if you look at, just look at the extremes, Black and white, you see Black unemployment was 6, went up to 16, came down to 9.7. White was 3, went up to 14, came down to 5. And you could look at it in different ways. Look at it with education. You have the pre-recession of 5.7 going up to 21. Bottom right, 4-year degree or higher from pre-recession, 2% going up to 8%. Now, what is heartbreaking in particular about these inequities that were introduced by the very effort to mitigate COVID, which itself had its own inequities, is that it didn't have to be like this, and it's often not like this. In fact, we forget this now. It's like, I suspect at this point, many of you are saying, yes, I know that. But in fact, most recessions do not occur so inequitably. Look at 1990 recession. These are the previous 4 recessions. You have a 1990, 2000, 2008 recessions and coronavirus recessions. And what you see is that The green line is the highest earning quartile. The purple line is the lowest earning quartile. And you see there actually isn't that splaying of those lines in the previous 3 recession. In the COVID crisis, we have this enormous splaying of the lines with the highest earning quartile versus the lowest earning quartile. And that is a direct function of the type of efforts that we took to mitigate COVID-19 without recognizing that some of those efforts that we took to mitigate COVID-19 were resulting in an even deepening of the inequities that COVID-19 was also causing directly. It's then no wonder that we saw during COVID-19 this legitimate surge in civil unrest, and which was, of course, catalyzed by the killing of unarmed Black women and men, centrally George Floyd, but also others. But the civil unrest, which was, by the way, the largest civil unrest the country's ever seen, about 10 to 20 million people were involved in protests in the summer of 2020, which is larger, substantially larger than 1968. It wasn't just about those particular incidents, right? It was actually reflecting on the observation of these deep-seated inequities that were emerging during COVID that clearly had been there for decades and centuries before that COVID brought to the fore. So having said that, let me ask this question. So why did it all go so wrong? Having pointed out some things that went wrong, why did it all go so wrong? Now, I could talk about a lot of elements of what went wrong, but what I'd like to focus on here for illustrative purposes, I'm going to focus on the Black-white difference in mortality. As I said, Black Americans were not the only group with a disproportionate burden of COVID-19, but I'm focusing on that group because there are very particular lessons to be learned for all other groups here. So why did we have such a Black-white difference in COVID mortality? And I feel, again, it's one of those things, we all know that happened, but we seldom stop to think, well, why did that happen? Well, there were two reasons why that happened. Number one, there was an unnecessary and unevenly distributed risk of getting COVID. Now, what do I mean by that? Well, how does one get COVID? One gets COVID through interpersonal transmission. It's a respiratory borne virus. How do you stop from getting COVID? It was by being away from other people, so you don't actually get respiratory transmission. And when is one at most risk of getting a virus like that? Well, it's when we're just learning about the virus, when it's all very new. So what happened in March of 2020? Well, March of 2020 happened, and a national emergency declaration was declared. That's in the yellow bubble right there. And people stay home, right? Well, not exactly. People in the top 20% of income stayed home much more than people in the bottom 20% of income. Now you may say, why is that? Well, maybe people in the bottom 20% of them just didn't want to stay home, and maybe they just chose not to stay home. As a result, they got COVID. Not so. The reason that people with lower incomes did not stay home is because they couldn't stay home. Why is that? Here's data from the Bureau of Labor Statistics. There's income quartile. The higher up you go in income quartile, the more able you are to work remotely. The more money you make, in other words, the more likely you are to be able to protect yourself from COVID. This is a classic dose-response relationship. Anybody who's ever taken epidemiology classes, Epidemiology 101. More of one thing, more of another thing. Higher income, more able you are to work remotely. Remember, I showed you earlier that job loss was concentrated purely in the two lowest income quartile, which means that in those income quartiles, you were already at great risk of losing your job because employment was shutting down, let alone if you decided to say, I do not want to go into work because I'm worried about COVID. So in other words, people in the low wage earning groups had no choice but to go to work and as a result, be exposed to COVID and have a greater risk of getting COVID. And that also overlaps substantially with color, that Black African Americans are more likely to be working in essential industries, and which are also lower, typically lower paid jobs, and as a result, exposed to greater risk of getting COVID. So that's reason A. But it's not just the risk of getting COVID. It's also the risk of having severe COVID, because remember I said I'm going to explain COVID mortality. Well, why should Black Americans have greater risk of having severe COVID? Well, the question is, what is it that drives severity of COVID? Well, what drives severity of COVID is underlying conditions. This is data from the China CDC from February of 2020. So we've known this right from the beginning of COVID, that if you have underlying conditions like cardiovascular disease, diabetes, chronic respiratory disease, you are more likely to have severe COVID. In fact, one of the facts that I think has been poorly communicated in time of COVID is that if you had no underlying conditions, you're actually not likely to die from COVID at all. Well, who are the people in our society who have more underlying conditions? Here's one graph to show that. This goes by income decile. The more income you go into the right. The yellow bar is underlying medical illness that makes you vulnerable to COVID. The more income you have, the less likely you are to have underlying conditions make you vulnerable to COVID. By the way, the green bar is having long-standing mental health condition, which means the more income you have, you're less likely to have underlying mental health conditions, which also makes you less likely to have poor mental health after COVID, but that's a subject of another presentation. And it's not just income. Once again, the income picture is also complicated by race and ethnicity. This looks at risk factors like high blood pressure and diabetes among Black Americans versus white Americans. Black is the blue bars and white is the red bar. And you see that high blood pressure and diabetes are higher among Black Americans compared to white Americans at younger ages, middle ages, older ages. And this all reflects the legacy of decades and centuries of marginalization faced by groups in this country, particularly Black Americans. It goes back to, and of course, had its apotheosis with the institution of slavery. This is a map of the southern United States looking at enslaved African Americans, with the darker colors being where there were more enslaved African Americans. But even after slavery was over, it was then followed by Jim Crow laws and by a number of other policies, including policies like redlining, which is what this map shows here. Redlining fundamentally was a function of the federal government aiming to help Americans buy homes and to encourage banks to lend mortgages. Of course, part of that was the Homeowners Loan Corporation. And that Homeowners Loan Corporation was tasked with suggesting to banks areas where it was, quote, safe to lend money. Those were the green areas, yellow maybe, and the red areas where banks were not recommended to lend money. Those areas were areas where African Americans lived, which of course resulted in far lower homeownership rate among Black Americans, which resulted in less wealth accumulation to the state, resulted in fewer assets, resulting in poorer health, which makes Black Americans then greater risk of having severe COVID. So that's why what went wrong, which then brings us to this question. Okay, so why did we get this wrong? So like, why did we get it wrong? And I would argue there are two reasons why we got it wrong. We have underinvested in what makes us healthy, and we have underinvested in what could keep us healthy if a crisis happens. Remember, I started this talk by pointing out what it is that we got right, and I made the point that much of we got right because we had invested in those areas where we got right. So why did we get this wrong? Let's start with the first underinvestment. We underinvested in what makes us healthy. Now, what do I mean by that? Well, what does make us healthy? I'd like to tell you that through a story, telling a story of Blind Willie Johnson. Blind Willie Johnson was a blues player. We actually remember him today because we remember a bunch of his songs. And he was born in Texas at the turn of the 20th century. He was born sighted, but the story is that he lost his vision in a domestic violence incident when he was 7. Now, Blind Willie Johnson grew up poor, blind, Black in Texas. He learned to play the guitar and he made a living busking. Not a very good living, as you might imagine. He got married and him and his wife were living in a small house, which at one point burnt down. They were fine when the house burned down, but they had no money. So they went back to living in the burnt out shell of the house. In the 1940s, so this is when Blind Willie Johnson was in his 40s, Blind Willie Johnson developed malaria. Now, malaria in the southern United States in the 1940s was quite common, so it was not particularly unusual that he would develop malaria. In fact, many of you know the CDC, Centers for Disease Control, was initially started to help control malaria in the southern states. His wife took him to hospital, and he was turned away from hospital. And then he died. So the question is, what killed Blind Willie Johnson? Well, what killed him was malaria. Had he received treatment for malaria, he would have lived. But it wasn't just malaria that killed him, right? It was also poverty and homelessness and domestic violence and racism and poor access to care. And I have yet to meet anybody who I tell this story to who doesn't see that, who doesn't see intuitively that those forces all contributed to Blind Willie Johnson's death. Now, why am I telling the story? Because I'm telling the story because I think it makes clear what makes us healthy. What makes us healthy is the absence, in this case, of domestic violence, the availability of stable housing, the absence of racism, the full access to care. All of those are supposed to make us healthy. Malaria is just one aspect of our health. It is the clinical curative aspect of our health. And to bring this metaphor back to where I started, our triumphs in the time of COVID have been triumphs of investment in treating malaria metaphorically, because our triumphs have been in clinical care and in development of vaccines, which are approaches at treating a disease once it's already with us. Our failures, which I just showed you, have all been failures of investing in the other forces around us that keep us healthy, that give us long, healthy lives. So really, our failures are a direct result of our underinvestment, and our successes are a direct result of our investment, which should teach us that we need to be careful and invest wisely. Now, taking the Blind Willie Johnson story, I can show you this in this infographic, now a little bit more modern, health-friendly. This is from the Institute for Clinical Systems Improvement, showing health and medicine, healthcare at the bottom in the gray bars, about 20% of people's health. Other forces like health behaviors, tobacco use, diet, exercise, alcohol use, physical environment, family, social support, income, education. These are the forces that create most of our health. And we sort of know that. It's actually hard to argue against it. But despite the fact that we know it, that's not what we pay for. The figure on the left is the same as the colorful figure I showed you before. Now it's just in black and white because this was rendered for the book that just came out. And you see medicine is about 20%, healthy behavior is 30%, socioeconomic factors 40%. Those determinants are what drives our health. On the right, you have what we spend our money on. And we spend the vast majority of our money on medicine. That's 90% of what we spend our money on. And we spend a lot of money. This looks at our spending on health. The blue line on top is us as the US spending on health. The other colorful lines are all the other rational countries in the world. Everybody's spending more on health, but we spend about 40% more than the next closest competitor. And as we're doing that, we're spending less on the other things. Leaving aside Social Security, the light blue is healthcare programs. You see how that's increasing? Think of it as malaria. We're spending more and more on malaria. And think of the other spending. You see how that's shrinking? Think back to Blind Willie Johnson. Do you think that this more and more spending on malaria was going to help him? No, of course not, because he was never admitted to hospital. He was never going to get treatment for malaria. So this picture is a picture that says why we are deepening the health gaps that we have today. Because the Blind Willie Johnsons of the world who are on the losing side of the health gaps, we are actually putting in place things that are further disadvantaging them, which is really troubling and really sad. In fact, we have been paying the price for this long before COVID. This looks at our life expectancy. This goes all the way to 2015, so long before COVID. And the burgundy line is us. The other colorful lines are other high-income countries. And what you see is that we had 5-year less life expectancy than other high-income countries already before COVID, which means we choose as a country to live 5 years less than other high-income countries. Now, I'm using those words and I realize that they're somewhat disturbing because you're going to say to me, well, I don't choose to live 5 years less, to which my answer is, we choose. Our policy decisions reflect our society. Our society is us. So yeah, you're choosing, we're choosing. And that is really upsetting. And of course, this lower life expectancy, again, is not experienced evenly. This looks at Black versus white mortality rate, blue versus red, and you see Black mortality rate higher, younger ages, middle ages, older ages. When you take a look at us as a country with life expectancy on the y-axis and spending on the x-axis, you see that all the other countries, they cluster, right? They go up, more spending, more life expectancy, but not us. More spending and we fall off the curve with less achievement in life expectancy. In fact, health is the only sector where we spend more and get less. I challenge you to think of any other sector where we spend more and get less. You really can't. In fact, you can think of it at a personal level. Suppose I told you your smartphone was going to cost more than it did in any other high-income country, but it held less energy, it had less battery power, stored less data, and was slower. Would you even buy your smartphone? You probably wouldn't. But somehow we accept it on health, and we shouldn't. So reason A why we got it wrong is because we underinvest in the things that matter. And number two is we underinvest in what may have helped, and what may have helped in time of crisis is public health. There's a shrinking in state and local health department numbers. Most states spend less than $100 per person on public health. The darker the color here is means less money that's being spent on public health. And even though there have been efforts like the prevention fund that intend to spend more on public health, like the black bar line on top, we tend to underspend that with actual scheduled spending being substantially less because other areas nip away at public health money. In fact, in most local governments, they spend more on policing than they do on health. The red is where local governments spend more on policing, and the blue is where they spend more on health. So with this picture in mind, how do we seize the COVID-19 moment of opportunity, and how do we do better on health? Well, The good news or the bad news, depending on your perspective, depending if you're feeling glass half full or glass half empty, is that we know what to do. This is actually a piece I wrote in March of 2019, a year before COVID ever hit, saying we need a health new deal. And what I was arguing is that we need to understand how health is produced. And by understanding how health is produced, we should recognize that we need to invest differently, which is exactly what I'm telling you today. So the good news is, well, I guess we've known this for a while. The bad news is that I said this like before COVID, which could have actually avoided us a lot of problems had we done this during COVID. The other good news is that there remains confidence in medical scientists and scientists overall. This looks at confidence in some medical scientists on the left, scientists on the right, and it's actually going up in the public, which means I think that those of us in health have a particular responsibility, a real moral responsibility to articulate the causes of health so that we can create a healthier world. And I often feel like to do that, we are at this intersection of knowledge that can inform action and values that allow action. We need to be in the top right-hand corner where we generate the science, generate the data that can inform what we do, but also make sure that our values align with that action. Vaccines are a perfect example where we know that vaccines are efficacious. We know they can make a big difference, but they have been brought to bear in a society which is not ready for them, and the values often don't align with the vaccines. And that is a real problem. So we need to work on both the values and the knowledge. Now, before I conclude, given that it's hosted by University of Utah and that many of you are in some way or another, either in science or in the policy space, I want to talk a little bit about how we can do ever better science to help fulfill this mission that I'm articulating here. Because I would argue that there have been many ways in which our science has fallen short in a time of COVID, and I think that has not served us well. So I would argue that we fell short of our promise in a time of COVID in three ways. They're false certitude, contradiction without acknowledgement, and intolerance of disagreement. And let me highlight each one. Let me start with false certitude. Well, a lot of false certitude has been brought to bear with the distractions and the wrong turns that many of our models took in a time of COVID. Now, there's nothing wrong with models being wrong. There's everything wrong with wrong models being proposed to the world as the answer to everything. And that's often what has happened and what has been the case. And there has been predictably, correctly, quite a bit of backlash to that. There's a couple of newspaper articles about failures of influential COVID-19 models to justify lockdown. Should Professor Lockdown share the blame for slow response to COVID? Because we know, there's a quote from a paper about modeling, which I actually think is really good. There's a really good quote, a lot of stake. When, we need to be sure that models recognize fundamental limitations. Dynamic models are usable as long as they take into account the uncertainty of assumptions. If this is not the case, the results are on a par with assumptions or guesses. Now, we often are not willing to admit that we don't know. And this is where false certitude comes in. And this showed itself abundantly apparent during COVID. And as a result, I think we in science, we in health have not been able to fulfill our promise enough to help guide the world in the right way. And we do that because we keep saying, well, if people hear of our of the fact that we're uncertain, they might believe us less. But it's not true, actually. This is from a paper in Science that says committing uncertainty only exerts a minor effect on trust. Knowing this should allow academics and science communicators to be more transparent about the limits of human knowledge. In fact, we know that people are willing to accept it if we say we don't know. But somehow that has not been how we have operated in time of COVID. We've operated from a place of false certitude, which I think has earned health and science a lot of animosity, being witnessed principally in the time of vaccines. Second is contradiction without acknowledgement, that science operates in fits and starts. We find something else. But that is something to be explained to the public, not made seem like something that we wash away. Of course, the biggest contradiction on this has been the masking, first saying we don't need a mask to avoid coronavirus, and then saying, well, we're just going to delete all that because actually you do need a mask. Well, there's nothing wrong with us realizing science evolving and changing our mind, but there's everything wrong with pretending that we've deleted history. And third, and perhaps most egregious, is that we in science and in health have allowed heterodoxy to form very, very quickly, and we have not tolerated agreement. And that is deeply problematic given how complex, I'm going to get to in a second, the decisions that had to be made are. We quickly alighted on one course of action. A lot of the course of action was to mitigate the virus through very blunt efforts of social distancing without recognizing that those actually have many other implications for many groups. Perhaps the most egregious example of our intolerance disagreement was the utter rejection of the Great Barrington Declaration, which came out halfway through 2020. Just for example, the Union of Concerned Scientists calling it herding people to slaughter, dangerous fringe theory behind the Great Barrington Declaration. But if you read the Great Barrington Declaration, you see things like adapting measures to protect the vulnerable should be central aim of COVID. For example, nursing homes should use staff with acquired immunity and perform frequent testing. Retired people living at home should have groceries and all other essentials delivered to their home. That is not in any way herding people to slaughter. That is actually a very rational perspective. And there were things to disagree with the Great Barrington Declaration. I'm not in any way endorsing it. I'm simply saying that we, in the heat of the moment, did not have the space in our minds or in our heart to recognize their different perspectives. About school opening, Philadelphia schools are essentially teaching children to death, which is, of course, dramatic hyperbole against something which fundamentally probably should have stayed open. So why did we fall short of our promise? 3 reasons, I think. We're dealing with very complex systems. We are biased and groupthink. Let me talk about each one. Let me start with complexity of systems. Let me continue my schools theme. So as people know, there's been a lot of schools shut down around the country. And as a result, students have learned less. The pink is math scores in 19, and the green are math scores in 20. You see there's a leftward shift of the curve, which means that every grade kids are learning less, but it's not even, of course, because the kids who are learning less are particularly kids in schools with majority kids of color, which is the dark blue dots. Kids in white schools with predominantly white students are also learning less, but substantially less learning less. It's also true that schools in more affluent communities open up faster than schools with low-income kids. And all of this, by the way, against the backdrop where death for children from COVID is substantially less, that's the red, than death of children from car accidents. Essentially, it was safer for kids, it was more dangerous for kids to drive to school than to actually get to school. But despite that, we saw massive school shutdowns across the country, even though we know that education is perhaps the single biggest protective factor for health that one can have. This looks at mortality rate in 3 different groups, Hispanic, Black, white, but just focus on maybe on white on the right. What you see is this step function. The more education, from left to right, more education, the less the mortality. So actually by consigning a whole generation to having achieved less education, we are effectively creating higher mortality rate for this generation going forward. That's the complexity of the system we've been dealing with, which is then not at all surprising. In fact, it's actually heartening to know that there actually were protests against some of the ways we dealt with schools. Our biases. Those in positions of authority, positions that are able to make decisions that influence others, those are able to influence how others think and have substantial biases, and we need to be well aware of those. Just to start with a higher level, I'll start with the 116th Congress. These are the new members of 116th Congress as they were being sworn in. And Congress often criticized on the dimensions in which it underrepresents the population, but often we forget the biggest way in which Congress underrepresents, the yellow part of the pie here. Look at the proportion in Congress and the proportion in the country. If we're in person, I would ask you to tell me what you think the yellow proportion is, but since we're on Zoom, I'll tell you that is the proportion of people without a 4-year college degree. 65% of Americans don't have a college degree. Only 5% of members of Congress don't have a college degree. Now, I'm not saying that there isn't a benefit of a 4-year college degree, and in some respects, when people in Congress who are better educated, but I'm saying that the world looks very different when everybody you know is 4+ years college educated in a high wage job, who are able to work from home instantly when we create efforts to mitigate the spread of COVID, versus if you actually are surrounded by people who are in low wage jobs, who are at the risk of losing their jobs, and who know that they have no choice but to go to work and actually potentially get COVID. And that is a very different looking world. Within the academy, we are a left-leaning group. This looks at middle, right, left, far left. Fully 80% of people in the academy are middle or left of the road. And of course, the entire COVID moment was deeply politicized and partisanized, with right and left groups taking ownership of particular positions, which became ideological rather than being scientifically based. Another bias comes from this, which is actually, there's only one group that really did better than everybody else in the pandemic, and that's the group of people with postgraduate degrees. This looks at mental health, physical health, personal finances, personal life, work-life balance. Above the line means you got better, below the line means you got worse. And you see in different sets of grouping, everybody's getting worse, except this group right here, which is postgraduate education. So people with postgraduate education did well during the COVID pandemic. And when you are doing well, it influences, it is a bias on how you see the world. Focusing on, let's say, epidemiologists as one particular group within public health, you see that more than 3/4 of epidemiologists are white or Asian, quite substantial underrepresentation of Hispanic and Black epidemiologists, which also influences how we see the world. And third is groupthink, that we quickly succumbed to groupthink, including on ideas like this, on the idea of zero COVID, which was pushed forward by many prominent scientists, that we can somehow eliminate COVID, even though there's never any evidence that we're able to eliminate COVID, having eliminated only one disease, smallpox in the human species, and only one disease in the animal population. And in fact, the fact that COVID exists also in the animal population means it's almost impossible for us to eliminate it. This sort of acquires a little bit of a spherical cow component. Spherical cows is all a joke in science, assume a cow that's spherical of uniform density, which of course no such cow is. And so in theory, we could eliminate COVID, but in practice is highly unlikely. Whole countries have gone along with this. Australia was one of the last countries to drop this, the myth of potential zero COVID, but substantial effort has been distracted from doing things which actually we probably should have needed to do, which is build confidence in vaccines rather than trying to go down these paths, which fundamentally are misleading. And the partisan nature of this argument, which I think scientists have been wrapped up in, has been deeply troubling. The blue dots here represent Democratic neighborhoods. The red dots represent Republican neighborhoods. And all this shows is people living in bubbles. It actually shows that Democrats live in more bubbles than the Republicans, but bubbles defined as everybody around you being your same political party. And I'll show you a slide that I show my community, and you'll all have to think about how it applies to you. This is from a study that was done in 2019 before COVID, looking at the most tolerant and intolerant counties in America. Suffolk County, which is, by the way, the county where I'm sitting in right now, where my school sits, is the most intolerant county in America. It's a solidly blue county. And I say this because I actually do think that a lot of the health establishment, a lot of scientific establishment is blue or blue leaning. And often we have made the mistake, and we've seen this mistake, and we see it continuing into casting alternative perspectives on what we should be doing during COVID as a red provocation, when in fact, it really simply represents the plurality of ideas that we should be tolerating to get to a better place that fully understands the whole country. So I'll stop here with a quick call to reclaiming what I call liberal public health. By liberal, I don't mean left-leaning, I actually mean rooted in Renaissance values and in the values of the Enlightenment, through three approaches: through humility, compassion, and reform through reason. I'll start with epistemic humility, humility about knowledge. It's been very hard to be humble if you're in health in a pandemic, because newspapers keep running things like what epidemiologists are doing for Thanksgiving, what epidemiologists are doing for Christmas. It makes you feel kind of special, but that leads to arrogance, which is epistemic arrogance, tendency to overestimate our ability to predict when we're overconfident in our knowledge. And I think that arrogance can blind us from the real needs of populations, and the needs to particularly make sure that we are doing reflect the needs of diverse populations in a way, in an inclusive manner. Second is radical compassion. And I mean compassion intentionally rather than empathy. Empathy refers to, I don't want you to be hurt because I can see the world through your eyes. To my mind, that's a lesser virtue than the virtue of compassion, which says, actually, I don't want you to be hurt, not because I can see the world through your eyes, but simply because we have shared humanity in common. And what does that mean? Well, I'll go back to this graph here, which is ability to work from home and income quartile. These data are from before COVID. There's no surprise here that when we as a country say that our primary effort to mitigate COVID is going to be just everybody work from home, we have a profound responsibility to say, wait a second, a lot of people, and these are people with low wage earners, are not going to be able to work from home. What impact is this going to have on them? And to act accordingly. And we utterly and completely did not do that. We have a profound responsibility to say who's going to lose their job and who's going to stay unemployed. Those are people with low wage workers. And we have a responsibility to say, as we keep people at home, what's going to happen to drug overdose deaths, which are now shooting up to 93,000 deaths from overdose in 2020, fully 20,000 deaths more than the previous year. And finally, reform through reason, to actually recognize that the world gets better through a radical vision, but incremental progress that is inclusive, progress that brings with it people from all political stripes towards the end of creating a healthier world. There's a piece I wrote about just that, which got criticized quite a bit, mostly from the, I think from the left, because it seemed like I was arguing for taking things slowly. I wasn't. I'm actually being pragmatic, that you need a radical vision of a healthier world, which I think I'm articulating here, but recognizing the pragmatism needed to bring people along, all people along. And this is the book that I have coming out on Monday, which largely reflects what I've spoken about here and really is an effort to inject these thoughts into our public consciousness, recognizing there's going to be a lot of thinking about viruses, about vaccines, about treatments, but saying that unless we deal with these foundational forces, it's never going to be enough. And the next pandemic will find us as vulnerable as we were after this one. Thank you once again. Thank you for having me. It's really a privilege to be here with you all.
Dr. Galea, thank you for that. That was such a thoughtful analysis for what we have and continue to experience. If I could just echo your very first point, I was so happy to hear that a lot went right, and it's so difficult to remember that. Our colleague at Utah here, David Sunwall, has been trying to make that point over the past 6 months that a lot went right, and it makes me think about the 200 people at the University of Utah that I've been working with to keep COVID off campus and trying to flatten the curve in Utah. And I'm sure Boston University has had the same role. And I just want to acknowledge the efforts of the many of the people that are on this call today, the work that has gone in over the past 18 months and all the things that have gone right, despite it being very easy to enumerate the things that have gone wrong. So thank you so much for that talk. Let's pivot to our panel discussion. Our discussion moderator is Jessie Mandel, Deputy Director and Senior Health Policy Analyst at Voices for Utah Children. Jessie's work focuses on health coverage, access to care, prevention, and health equity for children, families, and communities in Utah. Prior to joining Voices for Utah Children, Jessie was a senior program planner with the City of San Francisco Department of Children, Youth, and their Families, where she worked on after-school and nutrition programs and policies. Jessie also worked as a policy researcher in Johannesburg, South Africa, and manages a CDC-funded Healthy Communities grant in Portland, Oregon. Jessie studied government and environmental science at Wesleyan University in Connecticut and has a master's degree from Portland State University in the Oregon Health and Science University School of Public Health. Jessie?
Thank you so much, Dr. Lacey, for that introduction. It is such an honor to be here today. Can you hear me all right? Terrific, awesome. Well, I'm so honored to be here and to have the opportunity to moderate this amazing panel. We're just gonna have a terrific conversation today. Dr. Galea, thank you so much for your compelling, your powerful talk. And I'm really appreciative too that you're going to spend some time with us and this panel to continue sharing your time to build off of your conversation so that we can situate what you said here in Utah and go a little bit deeper, because I think so much of what you said really resonated with us here in Utah and the challenges that we faced over the course of the pandemic. But before we jump into this discussion, I want to first briefly introduce our incredible panelists. And again, it's such an honor to be with you all. I'm going to briefly introduce you all, but please do check out the program for their full bio. At first, we have Dr. Valerie Flatus. And Dr. Flatus is University of Utah College of Nursing faculty, and she's also the inaugural Associate Dean for Equity, Diversity, Inclusion at the College of Nursing. Next, we have Dr. Lopez, Dr. Yvette Lopez. Many of you know as well, and she's professor at the Department of Family and Preventive Medicine, and also the director of Utah Area Health Education Centers, or Utah AHEC. And then finally, we have Dr. Jose Rodriguez, who currently serves as Associate Vice President for Health Equity, Diversity, and Inclusion here at the U. And he's also professor in the Department of Family and Preventive Medicine and Associate Medical Director at the Redwood Health Center. Thank you all panelists. And again, please check out the program. I only touched on their many accomplishments and contributions. But to kick things off, I really just initially wanted to hear from the panelists about what resonated with you, what jumped out at you from Dr. Galea's talk. I know many things probably did, but just some initial thoughts briefly to to ground our conversation and think about what his talk meant to you here in Utah. I think there's a lot of pieces to unpack, but just initial thoughts. So Dr. Flatus, let's start with you.
Thank you. Thanks for having me here. My initial thoughts as I was listening to Dr. Galea's presentation was about how things have changed with COVID, especially for the Black community. And my thoughts were around the Black community here in Utah. And initially, when I was talking to some of my women friends and one of the women's groups I belong to about COVID and the effects of COVID, there was a lot of misinformation given to people about COVID-19, and working with people to try to dispel that misinformation that they were getting, and also talking about the promotion of vaccines coming up and what that really meant to people in general. The other thing also was the working from home and how people could not work from home because they were in lower paying jobs. And that had quite an effect on people in our community.
Thank you for that. Yeah. Dr. Lopez, what about you?
Oh my gosh, Jesse, how to pick? It is a tremendous and very complete depiction of what went wrong. It's like, yes, every time he was saying something. For me, because I teach social and behavioral science and theory, this is behavioral theory, the false certitude, the contradiction without acknowledgement, those are all faux pas that we have to own, that added so much to the turmoil that was, seeing people dying and suffering throughout. And the other thing is the underinvestment. Because now we know, and we have known, and we have been ringing this bell of health inequities for a while now, and they don't seem to be getting better. And so, what to do with that? And that is to get people to, wake up and organize and change things.
Yeah, absolutely. Yeah, that underinvestment definitely spoke to me too, especially in our policy work. Yeah, so lots to talk about. Dr. Rodriguez, what about you?
Hi, thank you for having me here. I feel like I'm in a room of many, many like-minded people, because the two things I was thinking about were the disparity in the Black population and the underinvestment. And the thing that struck me the most is actually the intersection of those two, right? Because the underinvestment in the things that are going to prevent disease and prevent problems really disproportionately affects our Black and brown communities all over this country. And so, it was a poignant picture painted of how our own policies are really us choosing to live less time, choosing to essentially fund health inequities. That was an amazing point that was made.
Dr. Galea, hearing those thoughts, I was wondering too, hearing your talk, it resonated on so many levels. And I thought how you also, you talked about some of the more upstream factors that are affecting, our health, but also the failures of this moment and even within public health too. And I'm wondering, you talked about just the idea of kind of that groupthink model. And I wonder if you could apply that here to more of a red state, and where you think about, we're you're in Utah virtually, but it looks very different here. The politics look very different. The groupthink, or the propensity for groupthink can look very different. And two, I think, the focus on the individual versus the community in our policy decisions. And so I guess I'm just wondering, as you were thinking about your book and the solutions that you're driving to, where did you see sort of a more conservative, more red state model, and how did you sort of reconcile those differences that you see here?
Yeah, thank you. First of all, let me just echo the very last sentence last speaker said. We are choosing to fund health inequities. I actually think that's super powerful. That's a really nice formulation, because I think we often look at health inequities and say, well, they just are, and they are hard to get rid of. But actually, we are paying to create health inequities. I think it's an important frame. So first of all, let me just echo and thank you. And I may use that in my talk if that's okay, because I actually think it's really excellent. I think in the context of red state, blue state, right wing, left wing, the key is commonality. And I have yet to meet anybody who doesn't want their children to be healthy. Everybody wants their children to be healthy. It can be red, it can be blue, it could be purple, it could be green, doesn't matter. You want your children to be healthy. So then it becomes, how do we create the narratives to convince people that what it takes to be healthy is to create a world that generates health? And even more importantly, that unless we do that, we are not going to be able to be healthy. Now, we have a problem because it's very hard for us to imagine a way the world is not. And we think that the way it is today, which is this primacy of individual sick care, which is fundamentally what we have, a sick care system that we buy and sell, is the only way it has to be. And then we ascribe meaning to it. We say, well, America, individualism, you all are in the West, et cetera, myths and all that. But this is actually the product of very deliberate decisions that we have made and very deliberate efforts that have made to sell a particular vision of health. And I think we need to counter that by selling a different vision of health. Now, how do we do that? I think one does that with relentlessness and with more compelling narratives. I told some stories in my presentation because I'm trying to translate what otherwise are pretty dry graphs and figures. And I think we can all do that until we get to a place where sitting around the proverbial, kitchen table, where one is talking to one's grandmother, and you say, well, what's the most important thing for your health? I would argue today, most grandmas, using that sort of, colloquially, will say, my doctor and my pills. Well, we need everybody's grandmother to say, what's most important for my health is the fact that I have stable housing, I have an income that can keep me able to stay in my house, I live in a safe neighborhood where I'm not worried about getting shot when I go outside, I drink clean water, eat safe food, and I breathe clean air. So we need all of us, all our grandmothers, all our parents, all our children, all our cousins and our aunts to recognize that. And I don't think that is a blue state or red state issue. I mean, you saw in my critique of how we've done in science, I think I was fairly pointed in my critique of the public health embrace of one particular approach, oftentimes being married with blue politics. I actually think that's an enormous mistake. I think it's an enormous mistake because half the country's blue and half the country's red. And to me, if we say health is a universal concern, I sort of have no argument with that. One of the things that I've enjoyed doing in my books is I do talk radio, I do sort of a right-wing talk radio. I've never had anybody on right-wing talk radio say to me, no, I don't want to be healthy. Like, that's not true. People do want to be healthy. And people need to recognize what it is that makes them healthy. So I think the task is education and conversation. I have a colleague who says, if we disagree, it means we haven't talked long enough. And I sort of like that because that suggests, right, that the conversation needs to keep going. And it is on us to keep the conversation going. So I am honest about my frustration with anybody who sees health as a conversation about health among blue people only, because health is equally a concern of blue people and of red people, using the term intentionally. I hope you all understand that. And if only blue people are listening, you're doing something wrong. Like, the health conversation needs to be listened by everybody.
Yeah, absolutely. And a lot goes back to then what we do with those investments. But I think that's a terrific point. I want to pick up on that a little bit and think about what we can do as healthcare practitioners, as public health practitioners, and that distinction between health and healthcare that can often be a strange distinction, when we should be talking about health more broadly. I'm wondering, within the context of the work that our panelists are doing in healthcare, how you are bridging that divide and working more with community organizations, working with policies, how we can create a more integrated continuity of health in the work that you were doing, and how you're thinking about that going forward, in light of everything that's happened, how you're pivoting to broaden your this idea of what health means in your own work. So Dr. Lopez, I'm going to start with you because I know that this is very central to the work that you're doing and trying to do more community health and really broaden the notion of what health is. How are you thinking about this and approaching this?
Thank you so much. I feel as though when we start something, and I mean something even minimal, and we don't include community, we really waste time because they are able to tell the problems and they have to be part of the solutions to their peril. They cannot be brought at the end, to be in awe of what you developed for them, as we often do. And so to me, that is a great solution to integrate at least community health workers in what we do. In the case of educating students, that is also a great use of community health workers because in our state, which sometimes it's not as diverse in the classroom, from faculty or from a student body, it brings that diversity, it brings that opportunity for our students, our health profession students, to work with people that are diverse and to get to hear the context of these social determinants that jump off the page into that personal story that Dr. Galea is talking about and that we know is so effective. And so in creating a new workforce that has, that in their minds, fresh, is important.
Yeah, thank you for that. Dr. Rodriguez, what about you? How do you try and create those connections and challenge the notions of what healthcare and the work that you're doing?
So I do work in two areas, right? So there's a lot of policy that I work with in the university in making equity, diversity, and inclusion part of everything that we do. Kind of like this, it's a democratization point, right? Everybody. It's kind of what Dr. Galea said about, what is important in healthcare, the whole business of having clean water and having a good job and having a roof over our head. We have to democratize that message as well. And so in the policy world that I work in, I think we have to make policies that actually favor equitable decisions. In the healthcare world, where I actually provide hands-on care, I think there's a lot more upstream work that has to be done. When it's all over, I get reimbursed, my clinic gets reimbursed for me taking care of sick people. But for me doing preventive care, the reimbursement is actually less. And we've made some changes in how things got paid for this year. And things like annual physical exams actually got less money than they had in the past. And so we're actually paying for worse care. And one of the people in the chat, Dr. McGill, talked about the National Academy of Science, Engineering, and Medicine. They came out with a new report called Implementing High Quality Primary Care. And one of the first things that they said is we have to pay for this differently. And the way it is right now we pay doctors to deliver services. And that we need to start moving back from that and starting paying teams to actually provide health. And that's a whole revolution that we're all trying to see happen. And this is a hard thing because, there's income disparities and, some of our, if we talk about healthcare teams, we look at, race, ethnic diversity in those healthcare teams. At the high end of the pay scale, there's very little race, ethnic diversity and very little gender diversity. And at the low end of pay scale, there's lots of diversity there. And how do we make it so that those payments actually get closer to each other so we stop paying for inequities? And so part of my job is to push and to get the message out that we need to change and that we can afford to change. And most physicians, even though we are high wage earners, if you were to ask them if they were going to take a pay cut to take care of healthier patients, you would get 99.99999% of us saying, of course we would, because it's better for the community. But right now, the way that things are, it's very, very difficult to make that argument effectively.
Yeah, I absolutely agree. Dr. Galea, I'm going to send that question to you, but first I want to just hear from, your thoughts around the payment piece. But first, I just want to make sure, Dr. Flatas, I'd love to hear from your thoughts about just how you're thinking about this question too, because I know you've done a lot of work in thinking about this as well.
I have, and so my approach has been, I'm a nurse practitioner, so it's approaching it from a nurse's perspective and also working with various community groups. I'm an educator and I'm also a healthcare provider, but I've been more of an educator recently. And so working with various groups in the community, but also looking at developing policy with the various groups, and then also talking with people in the community, because I feel that people in the community can tell us, as Dr. Lopez said, what the issues are and what the problems are. And we have done an opposite approach in Salt Lake for a long time. One time I was sitting in church and a researcher came and wanted to present his proposal to the church members. And when after he was done, I was like, he's not gonna get any participants. And when I looked at them out at in the lobby, waiting for people to come to the table, no one came up to the table. And it was just not the right approach. And I feel that we really need to talk with people in the community. And I've been doing that for the last 10 years to find out what the issues are. And I've worked with various groups around that. So we have to have a different approach so that people will become educated and people are eager for the education.
Thank you for that. Yeah, and I'd like to return to that idea of like just how we approach our ideas of community and the power structures that we've built in there. But Dr. Galea, what are some of your thoughts about hearing this and to what Dr. Flata said and Dr. Lopez, and also to what Dr. Rodriguez said around the paying that we're paying for inequities. Of course, when you showed that slide around our investments, there's a lot of vested interest in keeping the current funding structures in place, and how do we begin to chip away at that and change that to the points that have been made?
Yeah, so thank you. I agree really almost with everything Dr. Flatas, Lopez, and Rodriguez said. There's one thing Dr. Rodriguez said, which I somewhat disagree with, where Dr. Rodriguez said 99.99% of physicians would accept less money if I want to agree with you, but I'm not so convinced. I'm not so convinced. And let me explain that a little bit. I don't mean that from a venal point of view. I think physicians nurses, health providers go into these professions for all the right reasons. But I think we build incentive structures that are very powerful and that embed inertia. That's actually quite difficult. So I think if one were to go to physicians and say, if you were to take less money and it's going to create healthier patients, I think you would face a proportion of people who say, well, actually, I signed up with a different set of expectations, and that's not what I want to do. And I think that reflects how hard it is to break inertia. And coming back to this, we are paying for health inequities. We are paying to live 5 years less than other countries. We are paying to have enormous health gaps. And we do that both because we do not understand this, and because we lack the compassion that should unite us in the context of our shared humanity. And I do think that uniting us around the notion that health is a universal value, that we all care about health, is an approach forward, which, by the way, is why I think deep social divisions are so problematic. I think deep social divisions are so problematic because they fracture us and emphasize that you don't care about me and I don't care about you. And in order to achieve health, we actually need a shared language of valuing health as a public good, as something that we all aspire towards. So that means that we have a little bit of a job ahead of us. I've written about and spoken about, for example, that love is necessary for hate, which I realize sounds trite almost when I say it this way, but I don't mean it that way. What I actually mean by love is, I mean the love of one's fellow human being, and recognizing that I want you to have the longest, healthiest life you can. You know why? Because I want it for all of us as humans. And I actually don't think that's a big stretch. I actually do think we understand health enough, but we have allowed all sorts of other things to divide how we look at health. And we have made the mistake of seeing health as both a zero-sum game and poor health as something that happens to them over there. So for example, one of the things that one sees all the time is this idea of, well, we care for the poor and we want to be charitable. Well, charity is no solution. The solution is making sure that we create the conditions that no one has undue poor health to begin with. And even the term like the poor should never be used because it is marginalizing and it is labeling people in a corner, right? And ultimately, the vision should be that health is not differential by simplistic axes of identity, that health should not be different just because you're green or purple or blue or tall or short. Like health should be there for all of us. And there's always going to be some randomness. There's always randomness in terms of bad luck in terms of getting diseases and not. But insofar as the vast majority of health, which actually is preventable, we should want to decouple that from axes of identity.
Thank you for that. There's so much here. I'm glad we have time because I feel I have many questions. I think just picking up on that identity question, or your point around identity and decoupling that. Before there, I see some questions from the audience, or one, and I also have a pre-submitted one that I will ask. But I want to just spend a moment on that because we're also, this talk. There's also this theme of intersectionality and thinking about multiple identities, and I'd love to hear, from the panelists how they think about, the intersectionality of identities, but also, how and with this idea of decoupling from identities too, and how you think about that in the work that you're doing and building, broader notions of health. I think just to pick up on that, Dr. Rodriguez, do you have thoughts about that? It's kind of a multi-pronged question.
Yeah, there's a lot of stuff there. As I think about the intersections of my identities, right? I'm a physician, I am Latino, I'm a father, I'm a son, I'm a partner. And I think of those as personal identities. And then I think of, where I can decouple the identities from, and then my political identity, which is a whole different issue. And I wish that there was an ability to kind of dissect some of this and decouple some of my identities from each other. And I'll tell you why. And that's in July, I went to visit my parents. And my parents and I are not on the same political, well, let's just say we're not in the same political universe. I won't say what they are. I won't say what I am. However, I went there after swearing on a stack of Bibles or whatever thing is holy to people that I wasn't going to go visit them until they got their vaccine. And then they made it clear to me that they wouldn't get it. And I think about it, if my parents were able to decouple their identities and able to actually see that health was the value there and not who is promoting health, I think things would have been different. My dad died on the 26th of August. And on the 24th of July, he straight up told me, I will not talk to you if all you want to talk about is vaccination. But had he been able to decouple that, I think things would have been better for him. He might have still died, but a COVID death is horrible. And I think about maybe if I could have decoupled my own identities and tried to focus on the fact that health is the common thing here, maybe that would have helped him.
May I jump in for a second? So first of all, Dr. Rodriguez, that was a very powerful story, and I'm really sorry about your dad. I just wanted to jump in on this decoupling idea that I'm actually jumping in because I couldn't agree more. I'm actually I'm leaning forward because I'm enthusiastic about this, because I do think that one of the problems, you can see me all, I'm like leaning forward. I'm like, because one of the challenges of the COVID years has been, look, we all saw it. big P national politics polarized everything about this pandemic. And it became, if you do X, I'm not even going to get into what X is, it's because you vote for Y. And to me, we lost the narrative. We lost the narrative that fundamentally the narrative should have been about health. And so I just think, Dr. Rodriguez, you said it so powerfully. I just wanted to underline, that's all. Thank you for sharing that.
Well, thank you for jumping in, Dr. Lea, and I am sorry, Dr. Rodriguez, thank you for sharing that as well. You know, Dr. Lopez, what thoughts do you have about this as well? I know that, I mean, this is an issue that it is personal. It does touch all of us and how we go forward in the work that we do.
One of the things that occurred to me, and Jose, you know how much you mean to me, I am reminded of a funny fact, which is that, you know, I'm Puerto Rican, born and raised. I came here as an adult, right? So we have a positive view of vaccines, always have. Always a vaccine comes up, people line up. I mean, that's just, you know, in the ethos of, and it shows even today that we have a better rate of vaccination. You know, we enjoy a higher rate of vaccination. I mean, almost complete success in the elder population, and etc. And it's not, God knows that we don't have politics, but they have not centered around the, you know, the whole hoopla of, well, that's, you know, invalid somehow because of your political view. So I traveled that road, you know, as a person that vaccinates, etc. I also traveled the road of the daughter of a person that grew up in rural areas, where you do not go to the doctor until you have exhausted every single other, starting with Vicks and going on. I know it's funny, everybody laughs at that, but seriously, Vicks is at the front line here. But so, and then I go into, you have no way of knowing this, Dr. Galea, but I am a person that has a disability, walking, you know, and so, you know, I have all these intersections because when you have a difficulty walking at home, that is like, oh, you know, almost fatal, right? People want you to sit down all the time. You know, they don't want you to like make an effort, like all of a sudden my hands don't work, you know, and so, which is sweet, but at the same time, you know, all these entanglements of definitions, and then I have to, you know, assert myself, which is a little shocking. What? We're just trying to help you, you know, that kind of thing. So all of these entwined in my identity, but also as a professional and all of these things. So we are, I mean, so many things, right? So to separate them, it's, I don't know, it's difficult. And sometimes just to share how entangled they are is useful. I think I do that with the students all the time. And I ask them to do the same with their own and try to understand it. The understanding has to begin with ourselves.
If I may, could just comment for a second, Dr. Lopez as well. Dr. Lopez, again, thank you for sharing. I think it is this complexity that makes it so abundantly clear how reductionist, simplistic, and harmful it is to say that health belongs to any particular political ideology, or that or that that politics should drive our approach to health. Fundamentally, health is such a complex expression of what we value as a society, and we should value as a society that each of us can live long, healthy lives and flourishing lives, and that should transcend color politics. But by color, I mean red, blue politics.
Yeah, I agree. I mean, Dr. Flatas, what about you? How did you think about these questions too?
Well, I'm not from Utah, I'm from Massachusetts, actually Boston. And so most of my family is there. I've been here for 26 years. What I've thought about a lot, because I talk with some of my colleagues about this at different times, are the fact that I'm Black, I'm a woman, and I have an advanced degree. And when I'm out in public, people don't see that. They just see the Black woman. And So you can imagine sometimes some of the things that I've been through living here in Utah based on that. I also have felt the duplicity of being a certain way at work and a certain way at home. And I've also felt some of the disparities regarding healthcare here in Utah when I've gone to see various providers over the years. So that has played a part into who I am as a nurse practitioner and as a, and so in dealing with that, I can understand it when I talk with patients from all groups. The other thing that comes into play is the mental health problems that we do have in the community, as well as in the Black community. And then people in the Black community saying a number one problem that they've had is not maternal child health. And we do have a high incidence of problems with that, but mental health is the issue. So how do you maintain your own mental health in dealing with all the health disparities that you've been seeing and dealing with your patients? And then you're also your own issues around race and gender, you know, here in a pretty red state. So I throw those questions out there for people to think about, you know, at various times, because of all the issues that we have had over the years with health disparities, also health inequities, and then trying to decrease the health disparities here in the state.
Yeah, absolutely. And it's that interplay between individual mental health, that, you know, and how it's to the community mental health and the trauma, the historical trauma. And, yeah, absolutely. I want to pick up on that. I'm almost, well, I wonder if any of the panelists want to respond to some of those questions that Dr. Flatus put out there. But what I'll do is pivot to this question, a pre-submitted question. I think some of you might have seen it, and I struggled with it when I saw it come in, but I think it relates, and I think it's a framing of some of the problems that we see that I think need to be lifted up. I think it's a framework that's out there that is worth unpacking and addressing, even if maybe the question that was pre-submitted doesn't sit as well with you as I struggled with a little bit. But the question that was pre-submitted was, how do we ensure that the pursuit of diversity does not compromise the pursuit of excellence? How do we ensure that the pursuit of diversity does not limit itself to arbitrary and irrelevant criteria? So I think that's a framework that gets put out a lot. And I want to address it. I want to bring that into this conversation and hear the panelists' thoughts about that. Because I think we need to reckon with that. We need to reckon with that in these conversations. So Dr. Galea, how about I start with you? Your thoughts about the question.
Yeah, I'll actually put in the chat, I've actually written about this. I actually wrote a piece about the false choice between excellence and diversity, and I'll send out the link right after. Not to give away the lead of the piece, but I think it's a false choice. I actually think excellence always comes from innovation and maintaining standards, and that without diversity, we are doomed to obsolescence. The metaphor that I use, if I may, just to take it down to a simple level, is that let's take the French croissant. You know, we all like, who's not to like a good croissant, right? So you say, okay, good. Well, does excellence in baking mean making only croissants? No, excellence in baking means excellence in baking means, yes, you make a good croissant, but you also make other pastries. Well, if you keep the same kind of baker who only knows how to make croissants, you're only going to ever make croissants. Excellence should mean that we actually introduce other people to baking, so we have good croissants, but also have other good baked goods. And that's true for everything we do as a society. So to my mind, you truly cannot have generative excellence and innovation unless you have diversity. So I actually think the whole thing is a false choice.
I absolutely agree. And I just want to interject that I put this question out there, but I think that, as you point to, it's a false choice. And that dichotomy, unfortunately, is there. I think, too, I wonder if I could just, and then I'm going to turn to the other panelists, too, and how you situate that question, Utah. I think it also gets to the measurement questions, which I know you brought up in your talk, like how we are measuring.
Yes. Yes.
And I wonder if you could just speak about that a little
Sure.
bit.
And this is actually sort of, this gets a little bit to the metaphor. I might just extend the metaphor. If you're telling me that, well, excellence means the only thing that matters is just croissants, we don't care about anything else. Well, okay, if you're going to say that, then you're obviating the diversity argument. But that is, to my mind, a inertia-driven, narrow view that says excellence is only, essentially, if you say that, you're saying excellence is what we did yesterday. No, excellence always should be forward-looking. And once you accept that excellence is forward-looking, then your unit of measurement is not the croissant, it's the full set of baked goods that we're doing. And that, by definition, needs to involve diversity of people in this metaphor in the baking kitchen.
Thank you. Dr. Rodriguez, what about you? I'm sure this is something you've seen this framing as well, and it's in here in Utah as well, and in other aspects of your life.
Absolutely. But I think the important thing I'm going to say is now I want to eat a croissant. So we'll start with
Me
that.
too, actually.
I think you did a great job selling it, but you're absolutely right on this. The thing that really concerns me about the false dichotomy is that it is a prevalent belief in certain areas and in certain populations. And so what do we need to do there? And, as essentially, as the associate vice president who's in charge of this for the University of Utah Health System, I have a choice here. I can address that directly and say, sorry, you're wrong. Or I can work with the people who are willing to hear new ways to do things and move beyond. And so that's a hard choice to choose and it applies a judgment. And I don't want to be that person that's judging people who have a false dichotomy as part of how they look at the world. I think that, the one thing that I'm grateful for is that there's plenty of research on this, and there's plenty of information and plenty of good science that shows that our obstacles towards becoming more excellent are actually our lack of diversity. And as we become more diverse, especially in our decision-making bodies, we actually make better decisions and move ahead quicker. And so what I would like to say is that when we look at this, we should really take time to kind of reframe it and say, diversity isn't the opposite of excellence. It actually is a quality or a measurement of excellence.
Absolutely. Thank you for that. And also the openness, which I think, I struggled with this question, and yet if we don't, address these openly and with some of the compassion that you've discussed, I think then we can't also move forward. So I appreciate that. Dr. Flatas, I'm wondering about you too, in your new role, your inaugural role as in College of Nursing, how you're also wrestling with these questions.
Oh, Jose and I talk a lot about these issues and with these questions. And my approach has been to want to talk to everyone that's working in the College of Nursing. So talking with the staff, the faculty, also talking with students. I just started this role in July. So it's like I'm doing kind of like a listening tour with folks within the college, as well as outside the college, around this role and how I can help in terms of innovation, creativity, although I have tons of ideas, lots of ideas. So, but I want to hear from them first, so that I can see how I'm going to go with it. So I've been listening, and I've listened a lot over the years because I've been on various task force and committees and talked with students, and I love to mentor students. So I've been listening a lot and gaining a lot of knowledge that way. But I agree that with the diversity piece, it would be pretty boring if we were not as diverse. And it's taken years for us to get even a little bit closer to developing and having more diversity in our program and the programs that we have at the college. So we're working on it, and we're going to keep working on it. If I have anything to say about it, we will keep working on it. And I'm very energetic, enthusiastic. And as you can see, I get to the points pretty quickly. So I don't hold that way at all. But I think we've got work to do, and we're going to do it.
Thank you for that. Dr. Lopez, what about you, and also thinking about the work in rural parts of the state that you are doing, broadening notions of working with communities across the state, how you reframe some of these issues and try and encourage health centers to shift the approaches that they take?
I tell you, it's very difficult because people internalize this. I myself internalized this, pre-SAT, SAT, that how has that predicted my success in life? I can tell you very little because, how could it possibly? English is my second language and the test is in English. Right there, you can see the problem. And then, but you internalize that. You think, oh, golly, I'm somehow inferior to someone that scored this or that, or, and then there's tests, to admit you into this meritocracy that measure what exactly. And so these are the things that keep people that are, you would have to believe that some people are inferior to others. You just would have to, if you think that it's because of excellence. No, it's because systems have kept some people from reaching that arena of where the meritocracy even begins. And so when we go into communities, we want to work with the parents of the junior high school student because they don't know the system. They don't know how to help their child. They may not have gone to college. And if you get lost in junior high, you miss the bus, honey. It's hard to get back on to the science courses and all the things that you need to then go into your health professions. So, lots of work to do. I can tell you that it's a false comfort that it gives our systems about keeping people out. Oh no, golly, we wish we had them here, but they didn't meet the bar that we set here, and that's just false. Sorry.
No. I was nodding and I forgot to unmute. Thank you. All of, I appreciate all of the comments that you shared and openness to these questions. I'm going to ask one final question, then we'll turn to a few questions that I see coming into the chat. And this will be, it's a big one, so unpack it and take pieces that you will. But it's, how do we bounce back? How do we go from here? I mean, Dr. Galea, one thing I really appreciate in your talk is that you didn't, you considered all the reasons that we might have gone astray, like what we didn't, challenges or, failures, I guess you could say, mistakes that were made. But public health is still under threat. It's still under attack right now. We're seeing that a lot here in Utah. And we've got, public health under threat at a policy level, at a funding level, and we've got a very burnt out workforce that's just, struggling. So I guess the question is, where do we go from here? How do we bounce back? How do we begin to move forward with these challenges?
Yeah, first of all, I think there's no question that there is a general fatigue in public health, which I think is well earned, and I think we should recognize that and acknowledge that. Secondly, I think this is an exciting time for health, an exciting time for public health, because there is a renaissance of ideas that many of which have lain fallow for a long time. And I think there is an opportunity to inflect the national health conversation in a way there has not been an opportunity to do so for the past 20 years. So I actually think adjusting for our fatigue and sort of feeling like, okay, we're feeling kind of squashed, which I think we all are, but let's just acknowledge that. Let's acknowledge that. And let's make sure that we all find the spaces that we need to find to reinvigorate ourselves. But just acknowledging that for a second. I think it's a really critical moment to change the conversation on health once and for all. And I think conversations like this are a key part of that. And I'm grateful to you for hosting such a conversation. And the more conversations like this we have, the more chance there is of us looking back on this and seeing it as the opportunity to move to a next normal, a better normal than the pre-COVID normal.
Dr. Rodriguez, what about you? I appreciate that. I also want to acknowledge a question came in the chat about, or a comment about bounce back, and that it's more than just bounce back, it's transformation. And I absolutely agree. And I think that's what you were also saying, Dr. Galea. It's more of a moment than just a ball. Getting back up to where we were, we need to, explode that. Dr. Rodriguez, what are your thoughts about this? And I also just want to acknowledge, we've been on a few panels over the course of the pandemic, Dr. Lopez as well. And so I feel like we've had sort of those different iterations of, get back to normal, new normal. What are your thoughts, and how do we address the, going forward in a transformative way, and also, the squashedness, if that can be a term that that we all feel as well.
So I think I'll start by first addressing the intense amount of burnout that there is everywhere. I work at a health center that treats many patients who come from underserved backgrounds, and we actually work at the health center that sees the most speakers of other languages other than English, than any other center in our network. And so we have committed people who are trying their best to help patients who are in circumstances and in a society that has disadvantaged them. All right. And so if you think about it, they're working as hard as they can in a place that's difficult to work. And so the fatigue is actually multiplied. So I think there's a movement here where we have to take care of the people who are trying to provide the care. And what that looks like, there's many wellness initiatives, there are many compensation models, and many other things that we can do as a system that can help mitigate some of this burnout. But I also think that, because of the burnout and because of this incredible pandemic that has just made raw the inequities that exist both in health and in healthcare, I think that the time is ripe for radical transformation, to take things that are like the ideas that came out in the NASEM report and actually implement them straight out the box. It's time to transform. It's going to be hard because it really does mean looking at what we've defined as meritocracy and changing that to be what it is, which it is selecting for privilege, and figuring out what the replacement is going to be, and what are the measurements that we're going to use to select people who are not just committed to helping others, but who are also committed to the elimination of the inequities that, as Dr. Galea said, that we're buying inequities with our money and our time. And so radical transformation means changing how we pay for care. It means taking care of the people who are trying to provide the care. And it also means working better with the teams to understand that the teams care for people, not just the provider, whether that's a physician or a nurse practitioner or a physician assistant or whatever.
Yeah, I absolutely agree. I think I think it's this idea of radical transformation in this moment. Absolutely. Dr. Flatas, what about you? And I was thinking about things that Dr. Rodriguez said while we were talking, and also just bringing it back to what your example around, being in church and people not wanting to be part of the research. Like that's a component too that, we haven't totally touched on in this conversation, but just the barriers, the trust, how are you thinking about not bouncing back, but transformation and burnout?
So recently I've been thinking a lot about trust, and part of my research was around what people felt about the healthcare system here in Utah. In doing my research for my dissertation, but what I talked with people about was their trust in the system. And then what people would bring up were the experiments around Tuskegee, the Tuskegee experiments, but also other issues that they've had with healthcare where they felt like they were guinea pigs for providers. Also feeling that providers weren't listening to their thoughts. So there was a lot in talking with people around COVID and COVID vaccine. There was a lot of mistrust in the system, and wondering what the long-term effects of vaccination would be, and then trying to talk with them about their understanding of what all that means. We did a lot of work that way early on, and there were a lot of panel discussions and webinars and things like that around those issues. I had a thought earlier while Dr. Rodriguez was talking, and I lost it, and it was around, it was around the team approach to care. And I had written down about teams. I wrote a note about teams, the team approach to care, and that we all need to work as a team. But who's going to pay for the team, and how is that, how is that going to happen with patients? And then I think we also have to have a team approach to communities, and talking with people in the community, and educating people in the community around health issues, and focus on social determinants of health. Not just you need this vaccine or that vaccine, but really, what is their housing like? What's their mental health like? Do they have enough to pay their bills? Because people, if they don't have enough to pay their bills, they're not going to think about going into a provider. And then also dispelling fear of going to see a provider. But I also think we need to have providers who look like them. So we need to increase the workforce. Anyway, I could go on and on. That's
I know this covers so many. I know every comment. I'm like, oh, well, let's take it here. But I know we are getting up against time. So what I'll do is, Dr. Lopez, I'll have you comment on this idea, and then we'll head into just final thoughts as well. Dr. Lopez, I want to give you thoughts because I know you've also, squashness, community. What are your thoughts?
Right. To me, I remain hopeful, mainly because my favorite thing of all that I do, and I do a lot of things, is still teaching and working with the students. And when we combine the students with the community, we transform. That is a way that we can transform things, because they are developing, evolving, knowing that this is a winning combination, and that it's not something that it would be nice to go to community. No, you have to go to community, that's where it happens. That's where it starts. And so I have yet to meet a student that is reticent to do this, honestly. And also the idea that students, and and I'm not saying that all students are, very young or Gen Zers or millennials, but they give me such hope, because they see this perhaps more than the people that are teaching, faculty like me. You know, they see that there's a need for this, there's a need for transformation of systems, there's a need for diversity among themselves. They highlight this as a concern. And they also want to be confident when they graduate to be able to, you know, be as effective as they can be and as they want to be. And so I'm very hopeful because I see they're embracing these changes of involving community from the beginning all the way to, you know, the clinic and beyond, you know. And so while we reach diversity, and that should always be still our goal, we include the community so that they are still getting that exposure and that experience with diverse groups that they cannot be exempt from. If we're going to produce the best professionals out there, and I believe that we can.
Thank you for that, and for that, the hopeful note too. I always appreciate that, that you bring that. Dr. Galea, one question that came in the chat that I do want to just, I think we've addressed, I don't know if you can all see those questions, but one that came through that I think as we're closing up here, I wonder if you could include in your thoughts is commenting more about radical compassion, the role of compassion cultivation in developing mindful individuals in teams and addressing transient problems. I'm wondering if you can, you know, if you have thoughts about that and comment a little bit more as we.
Yeah, I suppose I have come to feel that we will not advance in promoting health unless we truly embrace the compassionate approach to health, which means a collective desire to make sure that each of us are as healthy as can be. That is what compassion is. And Martin Luther King had, who was perhaps the most famous university alum of my university, Boston University, had a quote, which I may not get it exactly right, but he said that compassion is not flinging a coin to a beggar. It is asking why they are a beggar to begin with. Those were his words. And I think that corresponds exactly with this entire conversation. And I think we have historically allowed charity and visible acts of kindness replace the much more important kindness of compassion, of saying we should be buying a world where everybody is healthy, not a world where people are, some people are health haves and some people are health have-nots. And we should be uncompromising on that. And that should guide what we do and how we think. That's what I mean by radical compassion.
I think that's so hopeful. I almost feel like that's such a beautiful place to leave it, this conversation, because that's, you know, we've talked about so much, but I just appreciate those words. And I think that really sums up, you know, a lot of where we have to go from here and the problems that we have ahead of us, how we can go forward. So I'm going to end it there, but I want to just thank you all so much for your time. Dr. Galea, thank you for spending time here in Utah with us virtually. Hope someday you can come visit our state too. And to our incredible panelists, it's such an honor to work with you, to work be in a state with you, to be on this journey together. You inspire me, and I know you inspire so many of us to keep working and to move towards to take this motion. Yes.
I wanted to add something. Do you remember last year we had Dr. Camara Jones, and she gave us homework, remember? She said to go and into the legislature at whatever level and make racism a public health problem. Do you remember that?
Absolutely.
Well, I am just so proud to report, and maybe Dr. Lacey wants to jump in this, but among the people that worked in this were, you know, Utah AHEC scholars. I'm sorry, you know, because they organized with with other people that moved this forward, and for this Salt Lake City that became a reality. And so I wanted to ask Dr. Galea for homework for us to do so that we are charged with something new.
That is easy. That's easy. I've said this earlier. I would like everybody here to convince 10 people of an approach to health that is a compassionate approach where, based on our shared humanity, you say we need to change the conditions that make us healthy. You convince 10 people. That's all. That's my homework.
All right, you heard it. Thank you, Dr. Galea.
Dr. Lopez, I'm going to turn over you. Thank you as well. And I've got my homework. We've all got our homework. So thank you again. Dr. Lopez, to you.
Thank you so much, everyone. My heart is full. Thank you.
Thank you to this panel. Thank you to all of the attendees today. Jesse, thank you for being here to moderate this session. Yvette, Valerie, Jose, thank you so much for the conversation. And Sandro Galea, thank you for visiting us with us today. I know our AHEC scholars and all of us will continue this conversation into the future with your new book, The Contagion, next time. I know we're looking forward to digging into that beginning next week. Dr. Yaz Simonian will close us out for today.
Am I on?
Yes.
Oh, okay. This was so fascinating. So wonderful. Good afternoon, everyone. So good to be with you. It is with pleasure that I bring our 6th annual Primary Care Summit to a close with a few remarks. Wow, what a great and informative summit it has been. Thank you, everyone. And congratulations to the presenters for a job well done. To the participants, I hope you feel well-informed, updated, invigorated, and ready to tackle the health inequities. Thank you, Dr. Sandro Galea, for your eloquent presentation. Now, I would like to share a little story with you. When I first heard Dr. Galea's presentation on how health is threatened by hate, I was touched with his story and felt a sincere connection with him. And here's why. He was born in Malta and immigrated to Canada with his loving family during his high school years. I was born in Iran and immigrated to the United States with my loving family during the high school years. However, unlike Dr. Galea, I was not started with snow since we did have snow in Iran, but high school cafeteria food did really shock me. No croissants there. My mom was a great cook. And we usually ate food that we could identify. One of the advantages of going to a high school that had many Hispanic and Polynesian students was that it made it easier not to be the same. It was okay not to be the same and be the one and only Armenian among the rest. It did take a while to be accepted and not to be called the camel jockey. I had never seen a camel until I visited the Salt Lake Hogle Zoo. We had double-decker buses from England and Mercedes-Benz taxis in Tehran, but not camels. I signed up for a Spanish class so I could learn English and English grammar at the same time. I watched Bewitched and I Dream of Jeannie on TV and practiced my English by repeating the dialogue and twitching my nose. The day when I understood MASH was the day I considered myself victorious with the English language. If you remember, MASH was full of slang and unconventional language. When we came to the United States, we were complete strangers, and not speaking the language made it even more difficult. The ordinary life was not so regular for us. Just like Dr. Galea's father, immigration was very difficult and hard for my dad. He was a dentist and could not practice his trade without the equivalent education and the language. He consequently found a place by working as a dental technician. He was really excellent at it. With the love of our family and relatives, together with compassion, kindness, direction of our friends, neighbors that helped with the community, we made it. Love of fellow human being, when you said that, Dr. Galea, is truly necessary for health and well-being. Dr. Galea and his family found their way to be greatly successful. He's an internationally well-known physician, epidemiologist, author, and a great educator, like we heard him right now. He has dedicated his work by embracing love as means of creating a world that generates health. So we need to look for that. One of the main reasons our family immigrated to the United States, the land of our opportunity, was to obtain education for my brother and me so we can have better lives. When I was 8 years old, my maternal grandmother was terminally ill with colon cancer. It was then when I promised her that I will go to America and find a cure for cancer. I was 15 when we made it. The years of education and hard work allowed me to conduct research and work in hematology and oncology division. I did not find the cure for cancer, but I added few closer steps for my students and the others to continue their research. I've been teaching for over 40 years, and I'm so very proud of all of our graduates who serve in the field of medicine and healthcare all over the globe. It is very rewarding to still be in touch with so many of them. Speaking of workforce, we are facing a crucial shortage of personnel, as we hear in the news all the time, as we see in our hospitals. Elective surgeries have been canceled. Some hospital wards have been closed. Some routine services are not being offered at the present time. We have lost patients with treatable conditions due to lack of space in many of our ICUs. We have been using Air Force airplanes that usually have been used during wartime. These are planes that were converted to ICUs to transport critical patients from hospitals with no capacity to other hospitals at nearby states, and the story continues. It was reported that healthcare has lost 500,000 workers nationally since 2020. It is unbelievable and alarming. What are the variables that cause this? There's so many. We've talked about that. So many hours of work with no relief. Healthcare workers cannot handle losing many patients when they have been educated and trained to save lives and help people to get better. The anger and disrespect that they have endured is unbearable. They're not being appreciated. Burnout, as we've talked about, and more burnout was so evident for so many. Illnesses due to COVID, them losing lives, their family, loved ones losing lives. Earlier retirement suddenly looked really better than before. Leaving the field of healthcare altogether was another choice. Mental health, that's something we're really focusing on. Misinformation and lack of information, good information. What does it mean to all of ours, the educators, healthcare providers, and caregivers? How do we change our story of health? How do we change the conditions and find the tangible goods? How do we bring health back to our healthcare providers? How do we recruit students for our programs? How can we make sure our future is sound? How should we be thinking of what to do for the next pandemic, maybe in 2024, as you said, Dr. Galea? We talked about the state, you stated the priorities for health in the post-COVID area. Those are great lessons to learn. We talked about how what good things came about because of the pandemic. We're shortened time to produce vaccines and production of medications. What makes us healthy? So many factors, environment and health determines that we invest in. So invest wisely and do better science. That's what I've learned today.
Thank you so much. Thank you. Thank you, everyone. So I want to say thank you again to all the participants and all the people that joined us. We did a program from the heart and hope that it reached its destination. Thank you, Dr. Simonian.
Thank you for the opportunity.
Goodbye, everyone.